Hey guys, this is Kelsey Cleary. I'm at Pro Rehab in Evansville, Indiana, and today we're going to be talking about one of my low back pain patients. The patient is a 47-year-old female. She's an x-ray technician, and she was referred to us by an orthopedist for a lumbar sprain strain. I evaluated her on the 14th. Her chief complaint was low back pain and spasm. It began 9 days prior to the eval. You can see she had a low fear avoidance, and her photo and Westry scores are there as well. On the body diagram, P1, her primary complaint was lower lumbar, kind of lumbosacral junction area, was a constant pain, throbbing, aching, but with occasional sharp pains and spasms. And that could range anywhere from a 5 to an 8 out of 10. P2 was more of a numbness and a tingling type feeling, and this was in the posterior thigh. She rated it to be about a 5 out of 10. It was pretty much just constant, always there. For the most part, it stayed above her knee. Should get an occasional zing down into her calf, but mostly just above the knee. I felt like P1 and P2 were related just because she never had P2 without P1. Both came on at the same time, same mechanism, so they just seemed to be related. Go ahead and take a time out. Post your source of symptoms in Moodle. Here are my source of symptoms lists if you want to review those. So going into this eval, all I had was an order that said acute low back pain with spasm. So basically, my hypotheses are everything I think of when I think of acute low back pain. So disc herniation, a facet problem, muscle strain, fracture, and then other things that could kind of lead to an acute problem like degenerative joint disease or disc disease. As far as aggravating and easing factors go, she was pretty much baseline 5 out of 10, but what would aggravate her pain, her P1, was just increased activity, especially at work, walking. She was telling me that she's an x-ray technician, so the busier they were, the more her pain would increase, the quicker she had to get patients in and out, that would make her pain go up as well. The pain usually, like I said, started at about 5 out of 10 for baseline and would start to increase about 2 to 4 hours into her workday, just depending on the day and what she was doing and how busy they were. Stooping, so just like bending down, trying to pick something up off the floor, was also a big aggravating factor for her that could increase her pain up to an 8 out of 10. For P1 easing factors, she liked to just lie down, prop some pillows up under her knees. She had a TENS unit that she liked to use. It usually took her about 2 hours after she got home from work to just kind of lie down, use her TENS unit, and let the pain ease back down to baseline. P2 had pretty similar aggravating factors to P1, just any kind of increased activity up on her feet, walking around, would cause that numbness and tingling feeling in her leg to increase. It would also increase when she was sitting if she had weight through the right leg. P2 is eased pretty much by the same thing as P1, lying down, pillows under the knees, resting, but also just changing positions. So if she had been sitting and weight on the right leg started to increase her P2 symptoms, she would either change positions, shift her weight to her left, or stand up. That would help relieve P2. For her 24-hour pattern, she started out stiff in the morning when she woke up, but then with a hot shower, some exercises and stretching, that made her loosen up a little bit, and she felt better for a few hours. But then as the day went on and as she got busier at work, her pain would start to increase and would pretty much continue to increase until the end of the workday when she was able to go home and rest. Her symptoms are just 9 days in duration, so pretty acute. They were caused when she was helping, I think, two other people. She was helping them to lift a paraplegic patient up onto the x-ray table at work, and she felt a sharp pain in her back, and then she said that her back locked up. So this was 9 days ago. She said she feels a little better this week than last week, but still she's getting worse with activities. She's having trouble at work. She was put on a 10-pound lifting restriction by her doctor, so she is still working, but with that restriction. She actually did have a previous episode of similar low back pain about 3 or 4 years before, and she was treated here in our clinic. She had PT, she had a few lumbar injections, and she also was issued her TENS unit. That's where that came from. And she had really been doing pretty well for 3 years. She was keeping up with her exercises as she needed, using the TENS unit when she needed it, doing pretty well. And then as far as this new episode goes, she has not had any treatment. No comorbidities to speak of with this patient. No real medical history other than the one previous episode of low back pain that we just talked about. There were no red flags that came up. Yellow flags, just really the only thing I wanted to keep in mind was that numbness and tingling in the right leg. The patient had an MRI and an x-ray done before she came to see us, and what that showed was some pretty significant lumbar degeneration, as well as an annular tear of the L5 disc, but we were clear of any fracture. She had been described Celebrex and Neurontin by her physician for this problem. Okay, so go ahead and take your time out, post your asterisk signs, your hypotheses, and your sins in Moodle. And then we'll continue with the physical exam. So for our asterisk sign functional movement, I used a squat, which gave her pretty severe pain, about an 8 out of 10. Then we definitely want to do a neurological examination on this patient because of the numbness and tingling in the leg. And what I found with that was some diminished sensation to light touch on the right leg, the L4, L5, and S1 dermatome levels. And what the patient really reported with that was that she said it feels stronger on the left. She could feel it more on the left than she could on the right. She also had a diminished L3 patellar reflex on the right. Range of motion is also here on this slide. We do it probably a little differently at our clinic than some of you guys do. We show range of motion of the spine as a percentage. So that's what you're looking at here. You can see that her biggest deficit was definitely extension. She had only, excuse me, about 5% of her extension, and that increased her pain up to about a 7 out of 10 from her baseline, which would be 5. Flexion also increased her pain, but she had pretty good flexion. She could almost get her fingertips to the floor, so about 90% there with a slight increase in pain. She also had some increase in pain with side bending to the right, and that was more right-sided back pain with that. Rotation, pretty equal bilaterally, didn't increase her pain, but still limited in both directions. And then side bending to the left, slightly better than the side bending to the right, and that did not increase her pain either. So I wanted to talk a little bit about how this patient presented. I wasn't really expecting her to be as irritable as she was. Um, when we started with the lumbar range of motion, she had one hand on the table the whole time, kind of hanging on, trying to support herself. She looked unsteady to me, looked like she felt unstable. She used the table, she used her hand on her leg to help her stand back up from flexion, from side bending. So once we got her on the table, she was pretty guarded, had a hard time relaxing for me to screen out the lower extremity. Kind of really any kind of passive motion and even active motion would increase her pain. So she was really guarded, and I had a hard time screening the lower extremity due to that. Also had a hard time getting her prone. We actually weren't able to successfully get her into a prone position just due to irritability. So everything I did, I had to do in supine or in side lying, and I really just wasn't confidently able to clear out the lower extremity at the initial eval, just due to uh, what I was restricted to due to her irritability. So there's several things that I had to come back to at the second visit, and one of those would be clearing the lower extremity. So that was cleared at the second visit, not at the initial eval. As far as palpation goes, she was pretty generally all over sensitive to touch in the lumbar spine area. The paraspinals in the lumbar spine were fairly hypertonic, even maybe I would say spasm. They were really turned on. She was also tender to palpation bilaterally, piriformis, posterior hip, both sides, but left was a little bit worse than right. For segmental mobility, this was one thing I couldn't get done at the initial eval. So we came back to it at the second visit, and what I found was some hypermobility in the lumbar spine, about L3, L4, L5 area, and PAs of those segments actually they reproduced through P2, the numbness and tingling in the posterior thigh, and they also sent that numbness and tingling all the way down her leg and into her toes. That was something new that she had not experienced in the past that we were able to elicit there. For special testing, she had a positive slump bilaterally, also positive straight leg raise bilaterally. But I do want to mention the straight leg raise, those were positive for reproduction of back pain, not leg symptoms. And then positive for aberrant motion, like I talked about before. She really held onto the table with the lumbar range of motion screen. She used the table, she used her hands on her legs to kind of bring herself back up to standing with flexion and also with side bending. So then here you can see what I found with my muscle testing. I was able to reproduce P1 with resisted hip flexion, hip external rotation, and internal rotation bilaterally. I was also able to reproduce P2 with resisted right hip flexion and right knee extension. Okay, so that's about it for physical exam. Go ahead and post your primary hypotheses in Moodle and post any questions you have. I look forward to talking more about this with you guys on Thursday.